welcome to the next episode of eGPlearning Podblast. I'm Dr. Andy Foster here, and we've got a great interview planned with a very interesting GP called Keith Grimes. He's a GP, technologist, and a medical VR pioneer. So hopefully throughout the course of this Podblast episode, we will find out all about medical VR, why Keith gets excited about it, and find out how you health workers out there can potentially start getting into VR and using it yourselves. We'll try and capture any links or specific products that we mention in the show notes, so check out the show notes along with listening to the show. So Keith is here. We're on Skype and recording this that way. So hi Keith, great to be talking to you.
Hey Andy, good to meet you. Yeah, good to meet you online. Of course, we know each other from meeting before, but it's good to be speaking to you today.
Yeah, fantastic. So Keith, I've been following you for a while on Twitter and Facebook. But for those of you who haven't kind of met or seen you or been exposed to your ideas before, do you want to just introduce yourself to our listeners?
Yeah. No problem. Okay, so yeah, as I said, my name's Dr. Keith Grimes. I am the VR doctor, and I am a GP and a geek and a gamer. And that pretty much summarizes everything you really need to know about me. But in a little bit more detail, I trained in Aberdeen Medical University. I came out of that, did my usual round of house jobs, and went off to Australia for a year, came back and switched from my initial choice of working in emergency department to working in general practice. And I've been working in general practice in emergency or urgent care ever since. But that's kind of the clinical side of my story. Long before I wanted to become a doctor, I actually just wanted to be playing with technology and using technology. And my entire career has been an effort to try and mix the two. Even at medical school, I was, trying to do spreadsheets and patient databases and things like that. And I even did a chaos theory intercalated degree and did some programming about child heart rate variability. So I've done a bunch of weird things. And along the way, what's been interesting is that, so I've always been desperate to try and do tech in medicine. But even going back to when I came out of medical school back in the mid-90s and then, into the noughties and everything, everyone recognized that technology was going to be really useful. And it was good to have a doctor that was interested in technology, but they could never give me a job in it. So I took lots of jobs that people said, there's some tech in there, and eventually built up a big portfolio of jobs that had a little bit of tech here and a little bit of tech there. And one of the wonderful things about general practice is that you kind of get to do what you want inside medicine. And as I sort of grew in seniority, I just thought, to hell with all waiting around. I'm just going to get on and do things. So most recently, everything I've been doing with medicine and technology has been just getting out there and getting it done, using the technology that I use every day, using accessible stuff, connecting with people and working with patients to just try something new.
Oh, Keith, that's a really interesting story of your journey there. I kind of see a lot of parallels with myself there.
Yeah.
I've always been a geek into technology and things, and always been trying to find that way of melding that with medicine, which I suppose is part of this podcast that Gandhi and I are doing now. Keith, I'm going to jump in and just ask you a question. What was your first experience of VR? When did you first meet VR?
So I first met virtual reality, or at least the concept of virtual reality. I suppose like most people, I heard about it before I actually tried it. So I was lucky enough, so training in the early 90s, it was late 80s and early 90s VR's been around for a while, but that's when it first sort of hit popular culture and popular knowledge with the work of people like Jaron Lanier. And it was around about the same time as the sort of rise of the sort of cyberpunk movement. And so you had people like William Gibson and Bruce Sterling and also dance culture. So this kind of combination of things with me as a sort of a young medical student that liked his games and his tech all kind of boiled into one place. And I got really excited about the idea. I was really sort of swept up in the kind of transhumanist movement coming from the West Coast of the States and all that kind of thing. So virtual reality definitely featured very highly in that. And the trouble with virtual reality was that virtual reality promised a great deal, but the technology was kind of ropey. So how old was I when I first used virtual reality? I'd say I was probably about 20, 21. I used, if I remember rightly, it was Virtuality, which was like a kind of arcade machine type virtual reality. Probably, I think it was the Piccadilly. They used to have an arcade centre just near Piccadilly Circus in London. I came down and tried it with a game called Dactyl Nightmare, where you sort of walked on these platforms and tried to shoot another person. It was a 2-player game, I was so excited about being able to try it, and good grief was I upset when I did try it because because it was bloody awful, and it was nauseating, and it was a slow frame rate, and it was heartbreaking. But the ideas that we explored then had been explored in the years beforehand, and people have been sort of beavering away on virtual reality, clinical virtual reality, since then. And it was actually so I continue to use technology. I like all forms of technology, but back in 2012, someone called Palmer Luckey did something on Kickstarter. So what he was a young man. I think he was 17 or so, and he kind of hacked together a very cheap VR headset. Now, VR headsets have been around, but they were very, very expensive. And what he did is that he proposed that he was going to build one that was based on a kind of skiing goggle model. But some of the developments that he put in there dealt with some of the real problems of VR, namely latency, which is the response time between moving your head and changing the image. And he managed to bring that down a great deal and improve the field of view. So it didn't look like you were looking through a tiny tube, but it was more wide. And as a result of that, he sort of fired the starting gun on the sort of next wave of virtual reality, which we're kind of on the crest of just now.
Yeah, fantastic. So Palmer Luckey, that's the Oculus Rift guy, is that right?
That's right. Yeah, absolutely. Yeah. So Oculus Rift. Palmer Luckey brought out the Oculus Rift and developed that through a series of what called DK development kits, DK1, DK2, and then CV1, consumer version 1, came out. I think it was about 2 years ago. And actually, before it came out, it was bought up by Facebook, which caused a great howl of anguish in the kind of anti-Facebook brigade. But I suppose from my point of view, what it showed is that Facebook investing a large amount of money in this was actually indicating its belief in virtual reality as an important medium going forward. So, people have their own thoughts about whether Facebook is a force for good or not, but they've certainly invested very heavily, and they're working really hard to realize virtual reality, particularly social virtual reality.
Yeah, fantastic. I suppose they've got to make good on their investment, I guess, as well.
Oh, I'm sure that's true. I mean, they've got a lot of money sloshing around. Don't get me wrong, but yes, they're going to try and turn it into something.
Yeah. So what are the main differences between the technology back in the 90s when you were somewhat disappointed by your first experience and what they're doing now? What are the differences?
I mean, it's night and day, the differences, but it's much easier for me to sort of explain that when you tried virtual reality back in the 1990s, you could put it on your head and you could sort of go, oh yeah, I understand what you're trying to do. You could with a little bit of effort and a strong stomach, you could sort of, I can see what this is all about. And there was an awful lot of kind of work that you had to do. So it was an entertaining diversion. But now the main difference is you put it on your head and you don't have to work that way. Now you just put it on, and when it's done well, instantly you're just like, I don't need to ask any questions. I don't need to work hard. I am just somewhere else. And it's that sense of presence, that sense of immersion that all the new technologies delivered. So what are the new technologies? Well, there's display technology, there's sensor technology, there's increased processing power and graphics cards. There's the use of mobile phones, because of course the sort of entry point for a lot of people to VR is using their smartphones or cell phones with a Google Cardboard type setup, a sort of a low-cost VR headset. So essentially the technology became much, much cheaper, much more widespread thanks to cell phones and mobile phones, and much more rapidly immersive. And then when you layer it on top of all the other developments, of course, essentially the internet has existed after VR. I mean, it was there in prototype back in the early 90s, but now it's universal. So you've got all these kind of underpinning technologies. So that's why things seem to have got exponentially better.
Oh, great. So Keith, what was your first experience of VR in medicine or in a medical application?
Yeah, so I'd read a little bit about medical uses of VR. The interesting thing about VR and all the uses that are being proposed now is that exactly the same uses were proposed back in the early 90s, with the absence of social media, of course. And so, but the technology wasn't there, and so now you're seeing the same people revisiting these ideas. Now, from my point of view, I got my first VR headset, which was a Samsung Gear VR. I'm an Android phone user, and Samsung have a fantastic kind of mid-level, low-cost solution where you put your Samsung phone into it, and it gives you a really good experience. And so I got into it because I tried it with a friend, and really, really enjoyed it. Bought it and was playing around with it and enjoying it, but I was aware of the work of someone called Hoffman, who is a researcher who works with burns patients, and he'd used sort of laboratory quality virtual reality to help reduce pain and distress in patients who are having burns. Burns dressings changed, which, as everyone knows, or anyone clinical knows, is an excruciatingly painful and frequent occurrence for these poor people. And so he found that it helped reduce pain and anxiety in these groups. So I was aware of all this, but it was when I had the kit, and like I said, it was the other thing that kind of encouraged me to do it is that I'd been banging my head against the wall so long to try and to do technological work or tech changes or innovations in healthcare. And I just thought, I'm just going to start with myself. I had the kit, and then it was a patient. It was listening to the patients, and in this case, the sort of the seed idea was when one of my patients, who is an ex sort of keen amateur rugby player, we get on very well because I like my rugby, and we have a bit of banter about that. And he was telling me about all the fun fights he used to get involved in and stuff. But when he got a leg ulcer, he was really distressed and really anxious about it. And so I felt I couldn't really help him. And then that got me thinking about VR. And then the first patient that I used it on, which was in May 2016, was a lady who'd just given birth, and she was breastfeeding her child. And she'd had a large pilonidal abscess incised and drained, and she was coming in to have it packed. And again, very, very painful. And she was finding it really, really upsetting too. So I had all the kit. I knew this lady from before, we had a chat, and I said, well, you want to just give this a try? And yeah, she said, yeah, all right. And we went ahead and did it. And it was the experience of working with a patient on using a piece of like consumer technology, which really significantly reduced her pain, significantly reduced her anxiety. In fact, when we were using it over the course of that week, at one point, we had to tell her that we'd stop doing the dressing because she just didn't notice. Now, I'm aware that what I'm giving you here is, from a scientific evidence point of view, kind of the lowest quality evidence out there, and I've since used it many, many times. So I've got a lot of, cases that I can talk about, and it's all very anecdotal. But for those people that worry an awful lot about there's a huge amount of published, peer-reviewed evidence out there about how virtual reality can be used to help in these circumstances. I just took the step to say, you know what, I'm not going to wait for the NHS to get around giving me VR for my patients, because let's face it, that'll never happen, or at least not happen quickly. I just decided to go for it, and we had some success.
Yeah, that's a really good story there, Keith, because it sounds like you did something that was new and innovative, and I put myself in your shoes, and the sorts of things that might have held me back might have been just worrying about could there be a negative outcome,
Mm-hmm.
Will I be criticized for doing something that's new and different and that doesn't have an evidence base? So it's really admirable that you just went for it. But did you have any of those fears or reservations?
Yeah, absolutely, for sure. And look, don't get me wrong, I didn't go into this just thinking, oh, here we go, this is going to be fantastic. I mean, I did worry about it a little bit before I went through with it. So how did I address this the very first time? Well, I mean, the first thing, the basics of this is that I made sure that I shared everything with the patient in this particular situation. I explained what I understood to be the evidence. I explained what we were trying to achieve. And I ensured that the patient had a clear understanding and was able to give properly informed consent. That was the first thing to say. The second thing is that through all the time that I've spent working in technology and medicine, I've had some grounding in a number of different disciplines, including clinical governance, information governance, and most recently as a clinical safety officer for NHS Digital, so assessing risk. Now, these are skills or experiences that maybe other GPs might not have, but they're not terribly complex. I did everything I could to minimize risk, and I limited expectations on this one. We approached it collaboratively, and I made sure that I tried the experience first. I did a little bit of reading about what the potential downsides, which we might cover later on. But at some point you have to jump off the diving board. At some point, you have to do it. And I gave a talk in TEDx NHS back in 2016 on a topic called the See One, Do One, Teach One, which was about how you can adopt the JFDI principle, the just expletive do it approach, which I learned when I worked in Australia because I was in an emergency department in a rural setting, and I was fretting about doing things like, oh, how do I put this suprapubic catheter in? And the rather sort of gruff Australian consultant just went, look, it's a massive bladder, you can't miss it, just do it. That was quite a baptism of fire, and some people would have criticisms of it. But it helped me understand that sometimes you have to take that first step. Sometimes you have to do something that makes you scared. You can do everything you can to manage the risk, and general practice is wonderful for that. But sometimes you have to get on and do it. And then if you do it and you minimize the risks, it's then important that you then share what you found, which is what the next step that I did.
Keith, great story about just getting out there and just, as you say, just doing it. So that was the first time you did something with VR. What are you doing now with VR in your general practice?
Sure. So the way I use virtual reality just now is I'm still trying to scale it within my own practice, which has been a remarkably difficult thing. And this is something that will not surprise anyone working in innovation in healthcare or anything. The inertia to change is significant. But so how do I use it? Well, I have my headset. I still have to use my phone, although I've recently got a standalone headset. And I use content that I've either just off-the-shelf content, entertaining activities for patients. There are some specific medical uses which I've partnered up with companies like AltSpace VR in the States, who are testing some of their software. And then also I've developed some software at NHS Hack Day too. So we use a number of different applications with a number of different headsets. But how we use it is I use it for the sort of things that you'll see day in, day out coming into a practice. So dressing changes and wound care, minor surgery, joint injections for the very anxious patient, blood testing, blood sampling, immunizations for patients as well. We offer it to them if they wish that. And we're beginning to look at whether it can be used in women's health for cervical smears and coil insertion. The limitation on the coil insertion side of things is that the nurse that we have who used to do this is not with us anymore. So we don't have coil insertions within our practice. But there's quite a wide range of things that we're using it for to make day-to-day experience for patients and also for the staff that little bit easier. And so as we go through that, it gets a lot better.
Cool. So have you got to the stage where there are other people within the practice using it as well as you and following protocols that you've developed? Is that where you're at, or are you not quite there yet?
Not quite there yet. I mean, actually, one of the limitations for me so far has been that I've not had any money. I'm just using my own cash to do this. I'm like a lot of other people. I'm a busy GP, and so the idea. I don't want to go through all the faff of trying to get the money and getting people to pay for it. So I'd rather just shoulder the cost myself and then just do it, and then I've got control over it. But that's always going to limit its scaling. So what I've done is I've certainly worked with my nursing staff to draft. We've got a written consent procedure. I've got a standard operating procedure for the use of this. The trouble is that I can't leave my mobile phone and headset at the practice just yet. So it hasn't got to that point, which I think would allow it to take off, which is allowing the nursing staff to have access to it. I think if you want a doctor to use it, then you're facing a much sort of steeper cliff. I think if you get to a point where nurses or HCAs or other staff members are ready to use it, then that's when it would potentially pick up. So I'm still working with them on that. I'm hopeful that we're going to get this sorted soon. And then I'm also sharing with colleagues, other GPs in the area, and hopefully actually some of the things we talk about during this Podblast will be able to. Some people might be able to be interested and look about how they can take things on themselves.
Yeah. We'll certainly ask you at the end how other people can get in touch and get involved in the medical VR movement. You just mentioned the point of scaling there, and I was just going to ask sort of what do you see as the next step in terms of your use of VR in practice or others' use? Have you thought about scaling? Some of the other people we've spoken to have started companies and attracted finance via crowdsourcing, things like that. Have you thought about going forwards?
Sure.
And how you might do it?
Yes, yeah. So, well, the first thing I suppose we'll talk about a bit later is that after I did all this, I decided to form a Facebook group called VR Doctors, which anyone's welcome to join. I always say this. Typically, I was a sort of self-obsessed doctor. I just went, it's all about VR and it's about doctors. And of course, now that I've got the group set up, we talk about much more than VR. We talk about augmented reality, mixed reality, 360, and also I'm desperate keen for it not to be just doctors. We've got nurses, we've got developers, we've got patients, we've got academics, we've got all sorts working there. And so it becomes a place where people can collaborate and share knowledge. It's a very sort of supportive space. I hope people who use it would agree in this one. So how do I get involved in scaling this? Well, part of this is being able to share my expertise with people that are developing elsewhere. So it's about sort of amplifying signal for other people. I'm not doing it in a sort of paid or commercial sense just now. I'm more about just getting this going. Personally, so VR Doctors is now a company, a limited company, through which any of the projects that I'm going to be involved with, and there are some projects that we're developing internally, such as a simple virtual reality experience for patients who are having blood sampling. That sort of stuff would happen internally. I'm not quite at that point that other people are in terms of seeking funding for this or anything. I'm sort of, at the moment, it's kind of low level stuff. So I'm self-funding an awful lot of this, and then relying on the generosity of strangers and corporate sponsors and the like to move forward, and the ability to sort of speak publicly and panels and the like helps fund things going forward. So that's where I am in there. If I was going to commit harder in terms of my own practice, I'd be going to. So I'm a salaried GP, and my employer, I would go to them and see if they would be willing to invest in some of my time and some money to develop something a little further. I think that the important thing there is that I have a lot of the stuff that I'm doing with VR just now is all about improving patient experience. And patient experience is a difficult one to make an economic argument for. If you turn around and say, what are you doing with this? Well, I'm making the patient's time nicer. They're in less pain. They'll say, yeah, but does that mean you can see more patients, kind of thing? It's a little bit tricky to make an economic argument, but I don't think impossible. I think, if we can improve compliance with treatment and chronic disease management and making things more effective, reducing DNA rates, I think that's where you start making the economic argument. But I approach it from the doctor-patient point of view. I'm a doctor. I want to help patients. Is this helping patients? Yes. Well, I'm going to find a way to do it, whether someone's going to pay for it or not. And if that involves me just sharing this and helping other people, then that's the way I'm going to go.
Yeah, no, I think that's a good philosophy, and that's a really interesting point you make about the need to make an economic argument for something to be adopted. And I wonder if some of the new ways that we're being judged as practices now sort of open up that avenue a little bit. This would be a great thing to talk about at a CQC inspection, I think, for example.
Oh, yeah.
In demonstrating that you're a really innovative practice. So practice might want to adopt it for that reason. Also, NHS choice of scores, really important now. Patient feedback metrics, and it could really move that needle for practices. And it doesn't sound expensive. So
it really isn't that expensive. So I've been using hardware, which was my mobile phone plus a Gear VR headset. So the mobile phone's the expensive part of it. I mean, you think, everyone's got a mobile phone, but of course they don't. And so you're talking about £500-600 to invest in that solution. However, this year we have the launch of a number of what we call standalone VR headsets. So they provide a similar experience to something like Samsung Gear VR, which is the sort of middle level. So it's what I consider to be the sort of the minimum good quality VR experience for clinical use. So we've got, for example, Pico. Pico are a company that have very kindly loaned me a unit called the Goblin, and it's basically what we call a 3DOF headset, or 3 degrees of freedom, meaning that when you put it on, if you tip your head from side to side, look up and down, or sort of spin, it will simulate that, but you can't sort of step forward or crouch on the floor. That's 3 degrees of freedom, and that gives a pretty good VR experience. That's going to be about £250. I think you can buy them just now. They're bringing a 6 degrees of freedom one out later on this year. Oculus have the Oculus Go launching later on this year, £200. I've been lucky enough to have a go on that. That's a really very good VR experience with a lovely little, really good speaker system. So at £200 investment, and then whatever cost there might be for the software that you're running. Actually, that's a pretty low cost. And I think maybe, for example, like if I was speaking to a GP right now, and say, for example, you're a GP with an interest in women's health, you had some involvement in coil insertion, implant insertion, things like that, I would say that you could make a really good argument for the use of virtual reality at low cost to help make things more comfortable and convenient. If only because it might improve the experience of the patients. It might mean that they move through faster. I mean, you could make an argument and say, well, if you reduce anxiety and you reduce, distress, then, are you going to reduce the likelihood of cervical shock or anything like that when you're using inserting a coil? These are questions that need to be answered. But I'd start with something like that, or a doctor that was interested in minor surgery, or if you ran a phlebotomy clinic and you wanted to bring in those patients that avoided things. So those are the good areas to start, I reckon.
Yeah. Do you think there's more of a market for this in private practice, private clinics, perhaps, or more of an initial market there? I'm just thinking in terms of their perhaps areas where they're more concerned about delivering a patient, sort of upselling a little bit and delivering a really great patient experience as opposed to an ordinary one.
Yeah, I think you're right. I think, well, because private practice, because of the commercial pressures, it has to focus more on the consumer experience or the customer experience or the patient's experience. So I think obviously they will do as well, and use the right word there. It's an upsell to, why have X when you can have X plus VR, So I think from that side of things, yes. But remember, virtual reality is not just about making existing treatment more comfortable or effective. It's a treatment in and of itself. It's a training platform. It's an experiential platform. It's a place that you can consult and diagnose patients. So I think that VR is going to have some practical uses. You can already see people using virtual reality for phobia management and anxieties, and there's a couple of clinics in London that I'm aware of that use some VR hardware to do that right now. So, but you're right, it is mostly in the private sector, and then I'm aware of people doing some work with VR within the NHS that we may be going to talk about in a bit. But
yeah, cool. Might be worth just talking about some of the. We talked a lot about sort of pain control, pain management. And so are there some other areas, just to kind of touch base on some of the other areas where VR might be currently or in the future making an impact in medicine?
Yeah, well, so when I give talks about the use of virtual reality in medicine, I talk about what I call the 5 ways of virtual reality, which are kind of the 5 use categories. And they start with transforming existing treatments, much as I've explained to you just now. But then there's virtual reality as a form of therapy or treatment in itself, VR as a form of diagnostics, VR for education and training, and then the final one, which I talk about, expansion or expanding, which is expanding a person's understanding of because of the sense of immersion, it can really be helpful in delivering empathy, and so you can feel what it's like to be in a patient's shoes or a doctor's shoes, or be freed from limitations of your illness. So that's a kind of broad look at things. So if I'm going to make it a little bit more concrete, let's start with the treatment side of things. So I've already explained a little bit that virtual reality can be used as a treatment methodology for people with phobias. You can create a virtual environment that closely matches the sort of phobic stimuli for a patient, but you can grade it so you can have an area that's not so distressing all the way up to the full experience. You might think of a person who has a fear of heights, for example. And then in the physical world, or physical reality, the non-VR world, you can go through the usual processes to teach people how to manage their anxiety levels with breathing and breathing exercises and the like. And then you can gradually expose them to environments in the virtual world that would be either too distressing in the real world or just impossible to do. It's not many places that you can get fine control over putting a person at different height of building and things like that. So phobia is one area, and then also you can then start looking at areas like anxiety with mindfulness, and also anxiety reduction, depression. There's very interesting work done about embodiment, this sort of sense of putting yourself into an avatar in a virtual world, and as a result being able to counsel yourself. They're even using it in patients with psychotic disorders to help them experience what it's like to be in a persecutory environment, to learn techniques to manage it. So mental health is a big area for treatment. From the diagnostics point of view, by putting a person in a virtual environment, you're actually quite able to quantize their relationship with it or their interaction. So through gaze tracking, through their movement through an environment, and that data can then be used to identify illnesses. So, for example, you could use virtual reality and gaze tracking in younger children as an early indicator of autistic spectrum disorder or autism, because we do know from research evidence that children with autism, autistic spectrum disorder, tend to gaze. They don't tend to have the same sort of face focus that neurotypical children might have. So there's that side of things. The big one, the one that seems to be sort of charging ahead, the one that has the sort of most momentum at the moment, is about education and training. So you've got companies like Medical Realities, Shafi Ahmed and Steve Dan. Shafi, the virtual surgeon, and he's had some great success in building a platform which allows people to experience surgery in 360 for training people around the world. He's taking a very democratic approach to this. But then you've got his work on this platform. He's working towards building a virtual university, which is going to take its first intake in 2020 and have its first virtually trained doctors graduating in 2025. Then you've got people like Nick Perez, a friend of mine, who's done some really interesting work with 360 video and looking at the human factors of healthcare. So basically, I simply put, what's it like to be on the receiving end, or what's it, and that changes people's behavior. There's a procedure simulation. And then you start moving into the slightly more bizarre area, which is what's it like to have dementia? What's it like to have autism? What's it like to have the visual disorders that you get through poorly controlled diabetes? Artificial intelligence can help there too. So there's a huge range of different things it could be used for. And I like using this 5 ways heuristic, because it means that whenever I see a problem or I see a new technology with VR, I start to think, well, it's not just about like training. It's, how can this make a difference? What's it like to consult in VR if I have a full body sensation suit? What does that mean for healthcare? These things, they sound weird, and of course they're weird, but that's where we stand. That's why it's so exciting.
Yeah, we may get there in the future. Full body suits, who knows? Yeah. So that's a really exciting look at the future of VR. But there's for all the possibilities and promise, there's often downsides or risks. What are some of the risks or downsides of VR?
Yeah, it's funny when you speak to developers working in developers and business people, they're always like, "Oh, don't mention any downsides." Of course, there are downsides to this. We are doctors and clinicians. We understand that we must first do no harm. We have to be open and honest about the downsides of any treatment. Anyone that says there are no downsides to a treatment is obviously trying to sell you something, often snake oil. So I'm very happy to share what I think are the current downsides and how we might address them. Now, virtual reality, for a start, is not going to suit everyone. It's certainly not terribly helpful for people at the moment that have seizure disorder, in the same way that you wouldn't put people with photosensitive epilepsy. You'd want to be a little bit careful about using virtual reality with them, so I'm not using it with those people at the moment. Patients with significant dizziness symptoms, I would be careful about using this with. I would personally be a little bit careful about using this with people that had very significant psychotic illness, people who had post-traumatic stress disorder, unless I was very sure about this experience that I was passing them into. In terms of children, there's an awful lot of argument as to how young is too young. Some of the consumer units are saying 13 is the bottom age. Interestingly, I think Namco's arcade VR has lowered its age to 7 just in the last couple of days. I've certainly used VR with my nieces and nephews down to the age of 4, and they seem to get on fine. But that does not translate to me saying it's fine to use it with a 4-year-old patient. I mean, I have used this with patients around about the 6-year-old mark. I think that 6 is probably the lower end, and they seem to get on very well with it, actually.
So Keith, so what goes wrong? So if you use VR too early, what goes wrong? Do they just sort of completely freak out and don't understand the experience, or what happens?
So from my patients, the people that haven't gotten well with it, number one, they put it on, they go, I don't like it, it makes me feel dizzy or sick, okay? I mean, simulation sickness is well understood, and current technology is helpful, but yeah, you got to watch out for that. So people just say, oh, I don't like it, it's just, it's too claustrophobic, I don't like it, I feel dizzy. Some people don't like some of the experiences, they find them a little bit intense. I think we're at a point where a lot of the commercial VR experiences are a little bit like the dawn of cinema, with trains rushing towards you and roller coasters. VR's a very immersive medium, and a little goes a long way. So I think we have to watch that. And then one of the games that we have, because games work fantastically well because they bring focus as well as immersion. There's a game called Podblast, which, as far as I'm concerned, is pretty innocuous. You have a kind of head-mounted kind of gun that fires balls at these little teddy bears, and when you hit them, they just fall over. They giggle. But some people, some parents aren't terribly comfortable with the idea of any kind of guns or any kind of even simulated sort of cartoon violence. So there's that as well. And then the final thing to say, of course, infection control. I think at the moment there's not many clinically suitable VR headsets. The solutions are a little bit fudgy. You have to get extra inserts or paper covers, things like that.
Okay. So, Keith, I just want to move on to perhaps some of the projects that you're currently involved in. I think there are a few specific things that you're involved in and driving forwards. Do you want to tell us a little bit about those?
Yeah, sure. So the two projects I'm principally involved in at the moment that I can tell you about are, first of all, is Prevent ICU Delirium. Now, Prevent ICU Delirium came as a direct result from contact made by Mr. Sunil Bhudia, who's a consultant cardiovascular surgeon working at the Royal Brompton and Harefield. And he'd heard me speak at an event about my experience of using VR back in 2016. Now, the basics of it is that he's a cardiothoracic surgeon. He has elective patients that go into ICU, obviously because of the nature of the procedures that they're having, and there's a high rate of post-operative delirium in these patients. I mean, it's in, above 80% in some, when you look at some studies. Now, he's aware that if you can take a patient into ICU before they have their operation, it makes them less anxious about having their operation. But the study evidence also suggests that reduces post-operative delirium. So his question was, well, if we can pre-experience patients to going into intensive care, can we reduce post-operative delirium? And so I've done a wee bit of reading about it. Some of the audience might know a lot about it, but post-operative delirium can be really a significant issue, certainly a significant cost involved. Morbidity, mortality, delaying people in hospital, all those sort of things. So we got together and we worked with medical realities, and we're in the process of just putting together the final sort of product, which is what we're going to take to a small scale study to see if there's a signal, to look if we give people access to using virtual reality to experience what the patient journey might be like before they go to intensive care for the first time, will that reduce post-operative delirium? And the project's called Prevent ICU Delirium, and like all studies, it's short for something. So Prevent is psychological resilience using virtual reality exposure as a novel therapy for ICU delirium. So Prevent's in there somewhere. Prevent's easier to say, that's for sure. And you can look for some news about that over the next few months.
Oh, fantastic. And there's something else that you're involved in, which I'm not sure is directly related to VR. It might even be AR, but See What I See. What's that all about?
So See What I See is a project that I was involved in. I'm not directly involved in it at this very moment, but I was involved in the initiation of it and starting of this project and getting it going. So See What I See is an evaluation held in the Eastbourne, Hailsham, Seaford and Hastings and Rother CCGs with assistance of the Health Foundation funding and the Academic Health and Science Network for Kent, Surrey and Sussex. So they're the people that are involved in this. And what it involves is the use of a product called Expert Eye from a company called AMA. They're a French company, and they found a way of using Google Glass. And hopefully everyone will know what that was. They'll remember the bad side of it. But Google Glass is essentially smart glasses. It's a set of glasses that has a small screen and a camera on it. And it allows you to, in a simplistic augmented reality way, have images put on top of what you're seeing and record what's going on. Now, See What I See is an evaluation of the use of this technology to allow doctors to remotely visit care homes, in particular one care home and in Eastbourne. Been going for a few months now. We await the findings of that. That's specifically about using a head-mounted smart glass as a way of providing expert support to an in-the-field worker. So in this case, the in-the-field worker is a care home assistant, and the expert is a GP. But we're looking at also using this for paramedics, to have a clinician help a paramedic, or a hospital doctor help a non-specialist in the community too. So it's interesting how that's being added to the armamentarium of the techie doctor in our area.
Excellent. So is that something that is actually happening, on the ground, or people wearing these headsets? Yeah.
Yes, it's actually happening. It's actually live right now. I think they're trying to work up the numbers because, like all of these things, the technology is fine, but getting people to adopt this and get past the little sort of wrinkles, the main part, and the real world gets in the way of what seems beautifully simple on paper, of course. Yeah. But what I am hearing back is that it's working very well when they've got got it going. I think what's interesting about the technology is it's helping some doctors think about completely new ways of working. That's the really interesting thing.
Excellent. So Keith, I think we touched on this question a little bit earlier, but I was just wondering kind of where you see your role in realizing the benefits of VR in medicine. You know, are you a developer? Do you see yourself as a communicator and connector? You know, are you a businessman around this? You may have answered that. You know, where do you see your role?
I mean, my role is I kind of like to do a bit of all of it. Of course, that's the nature of all innovation. I mean, I'm sure it's the same for you. You kind of want to do everything. But if I think about the areas that I feel I'm particularly strong in, or I suppose what's more important is how can I best serve the clinical VR community? It's more as a sort of communicator and connector. Through VR doctors and learning about all aspects of clinical VR, talking about it, meeting people, and helping connect maybe developers that want to meet clinicians, or academics that want, some use case information, or patients that have problems. Connecting people together is something that I feel I do hopefully quite well, and then sharing their stories. So I think that's where I am. But I see myself as a user. I love VR. I love using it. I love playing with it. I love experimenting with it. And through programming with Unity and Vuforia, I like developing AR and VR experiences, but this is all hobby level, that side of things. What from a professional point of view, it's about learning about it and sharing.
Fantastic. I would agree. I think you're a great communicator, Keith. Actually, so I've been sort of following you on social media, Twitter. I've seen your blog, the VR Doctors Facebook page, and I think that's something that you actually do really, really well in terms of get the message out there. How did you get so good at that?
Thank you for that. It's something that I didn't kind of set out to do. I think when I think about, if I sort of give advice to people about how to use social media, so we're talking here about the use of social media. A lot of it was just based on me just using social media. I mean, if you try and explain social media to a person who doesn't use it, then you'll get a lot of blank stares. And you can't then expect a person, if you find a person in your organization and say, you're responsible for our Twitter feed, you're going to get a very inauthentic and kind of awful sort of expression of what you're trying to do. And so how I got competent at this and how I use it is essentially by using the platforms. I use Twitter, I use Facebook, I enjoy reading blogs, I enjoy watching vlogs, and as a result of engaging with that just for entertainment and social purposes, I think I've developed some of an understanding of the language and the grammar of doing this. And I think when it comes down to branding, what I'm observing in millennials and the next generation is they have been raised in a world not only that has internet, which I remember the internet coming around, but they've been with internet from the start. They've been with smartphones from the start. But they're also kind of developing their personal brand from the start as well. I mean, they have sometimes a quite carefully curated online presence. They're certainly very, very expert at this. So I'm not as good as, there are definitely people out there that are better at it, but I think that the way you get good at it is by doing it. Again, just get out there and do it. Be authentic. Don't be afraid of sharing yourself. If you're a clinician, certainly, or a doctor, remain professional. You know what the GMC guidelines are on this and everything like that. But I still think you have to be a human. You have to be yourself. And if you do that and have an authentic voice, then I think hopefully that's maybe what you picked up on. I'm me, and in the blogs, I'm me. You want that to be concordant.
Yeah, fantastic. I think if people are interested in that social media and personal branding side of things, I would invite them to have a look at your blog and your Twitter and your other online presences and learn a bit from there, because it's something that's impressive.
Thank you.
So, Keith, you must be really busy. What are your tips for people who want to carry on their medicine, obviously, but perhaps also develop some of their interest in technology and maybe combine them? So how do you do that and survive and remain sane?
Oh, well, I've been variably successful at that. That's the first thing to say. So my lesson to everyone is, my first thing to say to everyone is take care of yourself. Do not keep yourself too busy. Make sure you have your downtime. That's easy to say. It's harder to do. So that's the first thing to say. I would say that in terms of the clinical work that you do, I mean, in some ways, this is more of a life question, is that you want to make sure that you don't have so many commitments in terms of your work, or particularly financial commitments that stop you doing what you want to do. If you have so many commitments that you have to work 10 clinical sessions or 9 clinical sessions, you'll never fit this all in. At least you'll not fit it in the core hours. So be mindful about the things that you enjoy and try and pursue them. How do I fit it all in? Well, I fit it all in by basically pursuing the things that I would kind of do anyway. These are the things that I do for fun. And so if I'm doing the things that I do for fun in my clinical practice, then it doesn't feel like work. And that's probably how I kind of fit it all in. I'm still guilty of trying to do way too much. And that's something that I think I'll just have to learn to deal with. But definitely finding the things that I loved and not being afraid to just enjoy them and do them, and not be embarrassed to say that I'm a board gamer and a geek, and has allowed me to actually, oddly enough, find the role as a board gaming geeky doctor. Who knew that such a thing would exist? So people out there, maybe there's something that you do. You're an artist, you're a performer, you're a singer, you're a dancer, you're a sports person. That's why general practice is wonderful. There's always that little space, isn't there? There's always that little thing that you can do. But it starts by making sure that you don't overcommit to things that you don't have to.
Yeah, I fully agree with that, and I'm in the guilty of taking on too much camp as well, I think. Yeah, no, it's great. But you're right, general practice does have that flexibility to allow you to incorporate things that you enjoy, things that are a bit different. And there's always that ability to scale up and down your workload as well, which perhaps is absent in other specialities, particularly in hospital medicine and so forth.
Absolutely agree.
Keith, so if I were to give you, let's say, £10 million, and as a Keith, go away and do something great in medical VR, and that you could invest in someone else, you could go out and do something yourself, anything, but £10 million. What would you do? Well,
£10 million is a lot. Is both a lot of money and not much money, I suppose, when you're trying to do some things in VR. But what I would immediately do. So if I was going to try and do, I'd like to try and do something myself with that. There's plenty of other people out there, and you could easily drop 10 million on any number of amazing teams out there. But if I was going to try and do something that I think will really pay off in the future, I would like to use that money to develop two things. Number one, a really good, low-cost, clinically suitable VR headset. One that's easy to use, works for the largest number of people, very easy to clean, robust, all that kind of thing. I'd want to at least work with someone to make sure I got that in place so it could be used. And then the second thing that I'd like to be able to do is, I think that one of the things about virtual reality is I talk about virtual reality as having a kind of, what are the class effects and what are the specific effects. So the class effect is, I could put a person in any kind of VR experience and something would happen. So they'll be immersed, they'll be distracted, and away they go. And then you have the specifics. So I have a patient who has anxiety. If I put them on a beach, they'd be a bit relaxed, but what they really want is to be on in a forest. So there's the kind of customizing, which becomes to the sort of the experience specific side of things. And then as you start getting more and more specific, I theorize that you're going to get greater effect from this. Now, if I have to go out to a development company every single time I want something specific, VR will never work in medicine because it takes too long and it'll be too costly. So that £10 million I would use, well, what's left of it after the headset, would be to work a collaborative social VR space where patient and therapist could go into VR together and jointly create the space that they need for therapy. That is what I would spend my money on.
So kind of like a sort of software development kit for clinicians in VR.
Yeah. Well, I like to think. Yeah, I like to think of it. Yeah, I like to think of it as a medical Minecraft.
Oh, cool.
Yeah. So I have actually used Minecraft in this way, but basically, I want this to be accessible to absolutely everyone. So I think that, leaning on gaming technologies and having it so, literally patient and doctor stick the VR headset on, they share the same VR space, and then between them they use, assets to build the space and then deliver the healthcare that they need. That is what I think would be a wonderful thing to have.
Cool. That sounds like a really good plan. Just need to go out and get you that £10 million from somewhere, I guess.
Yeah, sure. So if there's anyone out there with £10 million, if there's any people, particularly in the West Coast of the States, that have a lot of money sloshing around that want to do something truly revolutionary, you know where to get. Well, you're going to find out in a minute how to get in touch with me.
Cool. So Keith, just going to finish off with a few quick fire questions before we end.
Yep.
So Keith, so if there's a GP, a nurse, a medic, or anybody else out there who wants to get into medical VR, I'm going to ask you what should they do? What's the kind of basic thing to get started? I'm going to say if you want to go to the next level, and then I'm going to say what if you want to go on to maybe develop some environments and things. So I'm just asking to get that basic entry level, what equipment would you go out and buy now from the shops?
So right now, whilst technically you can buy Google Cardboard, if you've got a smartphone, you can spend a $5 and get a VR headset. I'd actually advise people not to do that. That'll kind of put them off the use of it. So I would invest a little bit of money and get something like Samsung Gear VR, if you've got a Samsung Galaxy Series 6 or above. If you've got a Google Pixel phone, something like the Daydream, or if you want to invest something like a Pico, which you can buy just now or later on this year, an Oculus Go. I'd say that, if you want to go and buy a sort of cheaper headset, by all means, you'll get an idea of what it's about, but you won't really kind of, get the full effect. So that's the first thing to do. Second thing, then use it, play with it, do some fun things, watch some music videos, just understand it a little bit, and join VR doctors and speak to people. Okay, so that's the first bit, and then thereafter,
Keith, can I ask? So if I've got an iPhone, so a lot of us are out there with an iPhone, and I found there seems to be less options for iPhones in terms of VR. What would I do if I had an iPhone?
Well, you would sell it and get an Android phone, of course. But no, if you can't bring yourself to do that, and iPhones are quite nice, I'll admit that. It's tricky. Apple hasn't thrown in behind virtual reality. They've thrown in quite hard behind augmented reality, that's for sure. And they've got some lovely augmented reality applications, which is another discussion for another day. But for VR at the moment, they don't seem to have anything that's anywhere close to something even like Samsung Gear VR. So I think if you were an iPhone user, again, you could get a Google Cardboard style headset and explore some things, but you're not going to you're probably going to be slightly put off from what's possible.
Okay. So Keith, if we want to go to the next level up from that, what would be the equipment that we would be going out to buy?
Okay, so next level up from that, you'd maybe wanting to invest in something like an Oculus Rift or HTC Vive. These are the kind of high level of consumer VR at the moment. Whilst you can buy yourself something like Oculus Rift for about £350, HTC Vive a little bit more than that, they do require to be connected to a rather beastly PC. And with the recent hike in the price of graphics cards, I think you're going to be spending, somewhere north of £1,000 unless you already have a good gaming PC at home, and some people might. So that's definitely the next level. Although you can actually achieve an awful lot with standalones like Pico, Goblin. So that'd be the first thing. You'd want to connect with other developers and users. They're a really sort of lovely community. There's one person I particularly want to mention, a doctor called Farhan Ahmed, who's working up in the Lake District, and he's a full-time GP. I mean, he works almost 10 sessions a week, I think, but he somehow managed to develop something called PR in VR, which isn't what you think. It's pulmonary rehab in virtual reality.
Okay, I was worried there for a second.
Yeah, clarify this. And it's a surprisingly fully featured replacement for pulmonary rehab for patients. I mean, it works with an integrated saturation monitor. It allows people to do pulmonary rehab in their home, so it allows you to scale it and deliver. He's based up in Cumbria, so you can connect with people. That would be the next thing. You could attend some of the NHS Hack Day events. They're very worthwhile pursuing. And then if you've got any kind of coding sort of aspirations, things like Unity, Unreal are actually pretty easy to use, so you might want to try that.
Okay, cool. So Keith, feels like I've learned a lot more about VR in medicine. Certainly, it's good to experience your passion for the subject as well. That's been really impressive. Learned a lot. So Keith, if there's others out there like me who've they've learned a bit more about VR in medicine, think maybe I want to get involved, maybe I want to connect with other people who are interested in this topic, maybe I want to connect with Keith himself, how would they get in touch with you or get involved in the community?
Well, the first thing to say is I'm really happy for people just to get in touch with me directly. I like to engage with people in social media. So if you want to do that, I'm on Twitter. It's at Keith Grimes. My VR Doctor vlog is at the VR Doctor, all one word. And that's probably the best way to sort of make contact with me. There's also my VR Doctors Facebook group. You just go into Facebook and just type VR Doctors in the search bar and you'll find it, join up, and then you'll speak with people. You've also got my website where I try and post everything that I'm involved in. That's www.drgrimes.co.uk. Yeah, I mean that would be a really good starter for 10.
Fantastic. So, Keith, thanks so much for chatting to me and letting the listeners learn and hear all about your work in VR in medicine. It's been great talking, and so I guess I'm going to sign off. Any closing remarks, Keith?
All I would close with is that balancing up the busyness of my life and dealing with the stress of working in general practice has been massively improved by not fighting against the fact that I am a geek and I like to play with technology. And I want to say to all the people who are listening here right now that there is something that you love, that you do. And if you want to really, really excel and be resilient, you want to make sure you're able to express that, if possible, in your clinical work. And sometimes that takes a little bit of courage. And I would just encourage you to just go for it, because it's really helped me.
Oh, Keith, that is such great advice. So on that note, I'm going to sign off. This has been Andy Foster and Keith Grimes on the eGPlearning Podblast. Goodbye.
Goodbye.
Thanks. So that was our interview with Dr. Keith Grimes, GP and medical VR guru and evangelist. Thanks for taking the time to listen to this interview on the eGPlearning Podblast. Do take a look at the show notes, which should be somewhere around where you're listening to this now, for links to people, products and websites, all the things that were mentioned in the show. Please do comment and engage with us by contacting us on Twitter at Dr. A.W. Foster will get you in touch with me, at Dr. Keith Grimes will get you in touch with Keith, and at Dr. Gandalf52 for Gandhi, our co-host on the Podblast. We really love interacting and reading your comments. If you'd like to nominate or volunteer to be interviewed, or perhaps suggest topics, apps, technology that we should be taking a look at on the show, then please get in touch. Do check out our previous episodes. Leave reviews on the podcast platform of your choice. That would really help us in terms of rankings and ratings. And do look out for future episodes of the eGPlearning Podblast. Catch you soon.